In this video, we'll talk about classical Hodgkin's lymphoma. First, let's talk about its pathogenesis. Normally in the lymph node, B cells undergo somatic hypermutation to generate antibody diversity. However, sometimes this process does not go as planned. As a result, non-functional or crippled cells are generated. These cells have lost the expression of CD19, CD20, and immunoglobulins. Normally, these cells undergo apoptosis. But sometimes, due to EBV infection or other spontaneous mutations, NF-kappa B signaling pathway is activated. This pathway prevents apoptosis and leads to creation of immortal cells. These immortal cells have all the time in the world to acquire other mutations, and these cells will ultimately become Rich-Sternberg cells. Rich-Sternberg cells have two nuclei, also known as owl-eye nuclei, and express CD15 and CD30. This can be remembered with the mnemonic 15 multiplied by 2 equals to 30. These RS cells secrete variety of cytokines and chemokines to undergo a process known as crosstalk, in which they effectively talk or communicate with other immunoeffector cells. This leads to aggregation of few number of RS cells with large number of other immunoeffector cells. Neoplastic cells typically form less than 2% of total tumor mass. Interleukin-5 attracts eosinophils, while interleukin-9 attracts mast cells. These cells bind to CD30 of RS cells, which leads to their stimulation. Mast cells may be responsible for generalized pruritus seen in some patients with Hodgkin's lymphoma. Similarly, RS cells also secrete IL-13, which increases Th2 cells, and galectin, which indirectly decreases Th1 cells. Th2 cells also stimulate RS cells by binding to CD40. RS cells also create immunoprivileged status around them to evade immunological destruction. This is done with the help of PD-1 ligand, which inhibits cytotoxic T cells. Similarly, mutation of beta-2 microglobulin gene prevents antigen presentation by the tumor cells. Furthermore, galectin-1 stimulates T regulatory cells to produce immunosuppressive cytokines like IL-10 and TGF-beta. Classical Hodgkin's lymphoma has typical bimodal distribution. Although it is relatively rare, it is one of the most common cancers seen in young adults. Based on the types of immunoeffector cells surrounding the RS cells, classical Hodgkin's lymphoma can be divided to nodular sclerosis, mixed cellularity, lymphocyte-rich, lymphocyte-depleted types. Lymphocyte-depleted type is often confused with large-cell non-Hodgkin's lymphoma and is typically associated with HIV. Now, let's talk about clinical features. Painless rubbery lymphadenopathy, which spreads contagiously, is the classical presentation of classical Hodgkin's lymphoma. There may be pain in the lymph nodes with alcohol intake. Splenomegaly, hepatomegaly, and bone marrow involvement may also be seen. Similarly, B symptoms like fever, night sweats, and weight loss can also be present. The pattern of fever seen in Hodgkin's lymphoma is termed as pale Epstein fever. This is basically a relapsing remitting type of fever. Some unusual presentations of Hodgkin's lymphoma include erythema nodosum, severe itching, hypercalcemia, nephrotic syndrome, and paraneoplastic cerebellar degeneration. Severe itching may be due to interleukin-9 secreted by the RS cells, which stimulate the mast cells. Hypocalcemia may be due to exogenous production of vitamin D by the macrophages present within the tumor, and nephrotic syndrome may be due to the cytokines secreted by the RS cells itself. Now let's talk about the investigations that must be performed. CBC, ESR, and serum albumin are mandatory. FNAC is useless due to small mass of malignant cells present within the tumor. Rather, core biopsy or excisional biopsy is done and are considered to be gold standard. Bone marrow biopsy is avoided as bone marrow involvement is patchy and it rarely upstages the tumor. Instead, PET-CT scan is done to determine its extent. Echocardiography and pulmonary function tests are also done to monitor the chemotherapeutic toxicity. Now let's talk about Ann Arbor staging. For lymphatic sites, the staging is pretty straightforward. Stage 1 means involvement of only one lymphatic site. Stage 2 means involvement of 2 or more lymphatic sites on the same side of diaphragm. Stage 3 means involvement of 2 or more lymphatic sites on opposite sides of diaphragm. And finally, stage 4 means liver or bone marrow involvement. For extra lymphatic sites, staging is slightly confusing. Let's take a look at a figure first. Stage 1 implies localized involvement of one extra lymphatic site without locoregional involvement. Stage 2 implies localized involvement of one extra lymphatic site with regional lymph node involvement. And stage 4 implies diffuse involvement of extra lymphatic site or localized involvement with distant non-locoregional lymph node involvement. Now let's talk about the treatment. The challenge in Hodgkin's lymphoma is not curing the disease, as it inherently has high cure rates even in presence of metastasis. Rather, we want to prevent long-term complications of therapy. The bottom line for treatment is that for stages 1 and 2, chemotherapy as well as radiotherapy is used, while for stages 3 and 4, only chemotherapy is used. This figure illustrates the basics of treatment. For localized tumor, we use ABVD regimen with radiotherapy. We do not use radiotherapy in low-risk advanced disease. Rather, we only use ABVD chemotherapy. For high-risk advanced disease, we use BEA-COPP chemotherapy regimen instead. The escalation and de-escalation of treatment depends on the PET-CT findings, which is done typically in between the cycles. In case of relapse, salvage chemotherapy with autologous stem cell transplant is done. If the patients relapse again, then drugs like anti-CD30 brentuximab and anti-PD-1 pembrolizumab are used. Classical Hodgkin's lymphoma has a very good prognosis. For advanced Hodgkin's lymphoma, Hassen-Clever prognostication index can be used. It takes into account age, sex, albumin, hemoglobin, stage of the disease, WBC, and lymphocyte counts. For the survivors, annual breast screening, annual chest screening, annual TSH examination must be done. Similarly, cardiovascular risk factors should be screened for and modified.